Two people, both over 60, both taking a single pill every morning for blood pressure. One of them wakes up feeling roughly the same as they did a decade ago. The other has quietly accepted that afternoon exhaustion, that heavy, sluggish feeling by 3 o'clock, as simply a normal part of getting older. Here is what almost nobody tells either of them. The specific medication in that morning pill organizer may be the actual difference between those two experiences, not age itself. Amlodipine and metoprolol are two of the most commonly prescribed blood pressure medications in the world, frequently prescribed interchangeably, sometimes even prescribed together, and yet they work through completely different mechanisms in the body, and only one of them has a well-documented, mechanistically explainable relationship with fatigue. Today we are going through exactly how each of these medications actually works, why one of them is far more likely to be quietly draining your energy, and what that actually means if you are currently taking either one. Nothing here is a reason to stop or switch any medication on your own. This is the same information your doctor uses to think through this exact trade-off, laid out clearly enough that you can bring better questions to your next appointment. It helps to understand why this particular comparison matters so much before getting into the pharmacology itself. Both of these medications are frequently prescribed for the exact same reason, high blood pressure, which means a patient and their doctor often have a genuine choice between them, rather than one being the only available option for a given diagnosis. When two medications can achieve a similar end result, blood pressure lowered into a healthy range, but arrive there through entirely different mechanisms, the side effect profile of each becomes a genuinely important factor in deciding which one makes sense for a specific patient, especially when one of those side effects is something as broadly impactful on daily quality of life as chronic fatigue. Let's start with amlodipine, because understanding how it works makes the entire comparison much clearer. Amlodipine belongs to a class of drugs called calcium channel blockers, and more specifically, it belongs to a subclass called dihydropyridines. These medications work by blocking calcium from entering the smooth muscle cells lining your blood vessels. And since calcium is required for those muscle cells to contract, blocking it causes the blood vessels to relax and widen. Wider blood vessels mean less resistance for the heart to pump against, which is how amlodipine lowers blood pressure. Here is the detail that matters most for this entire comparison. Dihydropyridine calcium channel blockers like amlodipine act primarily on the blood vessels themselves, and only minimally on the heart's electrical conduction system or its pumping strength. This means amlodipine does not significantly slow your heart rate, and it does not meaningfully reduce how forcefully your heart contracts. The heart continues functioning at essentially its normal pace and normal strength, simply pumping against less resistance because the blood vessels have relaxed. This is precisely why fatigue is not considered a common or expected side effect of amlodipine specifically. The side effects most commonly associated with amlodipine instead relate directly to that blood vessel relaxation: ankle swelling from fluid shifting into tissue, occasional flushing or warmth in the face, and headaches in some patients, particularly when starting the medication, as the body adjusts to the new level of vascular relaxation. Some patients do report mild dizziness when starting amlodipine, typically tied to the blood pressure lowering effect itself rather than any reduction in cardiac output, and this tends to resolve within the first few weeks as the body adjusts to the new, lower baseline blood pressure. This dizziness is a fundamentally different phenomenon from the sustained, day-to-day fatigue associated with beta blockers, since it relates to a transient adjustment period rather than an ongoing reduction in the heart's actual working capacity during exertion. Now let's look at metoprolol, because this is where the mechanism changes entirely, and where the actual explanation for energy drain becomes clear. Metoprolol belongs to a completely different class of medication called beta blockers. Rather than acting on blood vessels the way amlodipine does, metoprolol works directly on the heart itself, specifically blocking beta receptors that respond to adrenaline and noradrenaline, the hormones responsible for speeding up your heart rate and increasing the force of each heartbeat during moments of stress, exertion, or excitement. By blocking these receptors, metoprolol slows the heart rate and reduces the force of each contraction, which lowers blood pressure and reduces the heart's overall oxygen demand, making it particularly useful not just for blood pressure, but for conditions like angina, certain arrhythmias, and recovery after a heart attack, where reducing the heart's workload carries genuine life-saving benefit. Here is precisely where the fatigue connection comes from, and it is not a vague, poorly understood side effect. It follows directly and predictably from the exact mechanism just described. Your heart's ability to increase its rate and pumping force during physical activity, called cardiac reserve, is what allows increased blood flow, and therefore increased oxygen delivery, to reach your muscles and brain when you need extra energy, whether that is climbing a flight of stairs, carrying groceries, or simply having an energetic conversation. Beta blockers like metoprolol directly blunt this reserve capacity, because they are specifically blocking the exact receptors responsible for that heart rate and contraction increase in the first place. Multiple studies measuring exercise capacity in patients taking beta blockers have found meaningfully reduced peak heart rate and reduced exercise tolerance compared to patients on other blood pressure medications, including calcium channel blockers, like amlodipine, an effect that is considered a direct, expected pharmacological consequence of the drug's mechanism, rather than an unusual or unexpected reaction in a small subset of patients. This is precisely why beta blockers are the class of medication athletes and fitness-minded patients most commonly ask their doctors about when they notice a decline in workout performance after starting a new prescription. And it is also why cardiologists specifically counsel patients starting a beta blocker to expect their maximum achievable heart rate during exercise to be noticeably lower than before, sometimes by 20 beats per minute or more, depending on the specific dose. This is not a malfunction or a sign that something has gone wrong. It is the medication working exactly as intended, deliberately capping how high the heart rate can climb during exertion, which is precisely the mechanism that provides the therapeutic benefit for conditions like angina in the first place, but which also directly explains why simple daily activities can start to feel more effortful than they used to. This matters even more specifically for people over 60, for a reason that compounds the effect further. Cardiac reserve, the heart's natural capacity to increase rate and output during exertion, already declines gradually with age even without any medication involved, as the heart's tissue becomes somewhat less responsive to adrenaline signaling over the decades. This means an older adult starting metoprolol is having their cardiac reserve blunted by the medication on top of a reserve that has already naturally narrowed somewhat with age, producing a combined effect that can feel considerably more noticeable than the same medication would feel in a younger patient with a larger baseline reserve to draw from. This is part of why fatigue related to beta blocker use tends to be reported more frequently and often more intensely among older patients specifically, compared to younger adults prescribed the exact same medication and dose. There is a useful way to think about this compounding effect. Imagine cardiac reserve as a kind of savings account the heart draws from during moments of physical demand, already gradually shrinking with age even before any medication enters the picture. A younger adult starting the same dose of metoprolol is drawing from a considerably larger account, so the percentage reduction, while real, may not be as noticeable in daily life. An older adult starting from an already smaller account experiences the same percentage reduction from a much thinner baseline, which is exactly why the same dose, the same medication, and the same mechanism can produce a meaningfully more noticeable effect purely as a function of age. There is another layer to this specific comparison worth understanding, because not all beta blockers behave identically, and metoprolol has a specific characteristic that separates it somewhat from other options within its own drug class. Beta blockers vary in how lipophilic they are, meaning how easily they dissolve in fat and cross into fatty tissue, including the fatty tissue that makes up much of the brain, called the blood-brain barrier. Metoprolol is considered moderately lipophilic, meaning it crosses into the brain more readily than some other beta blockers, like atenolol, which is more water-soluble and crosses the blood-brain barrier considerably less. This distinction matters because beta receptors exist within the brain and central nervous system as well as the heart, and blocking those central receptors has been specifically associated with a distinct category of side effects beyond the general cardiac fatigue already discussed, including sleep disturbances, vivid dreams, and a specific kind of mental fog or sluggishness that some patients describe as feeling different from ordinary tiredness, more like a general dulling of mental sharpness throughout the day. Not every patient taking metoprolol experiences this central nervous system-related effect, and individual sensitivity varies considerably, but it represents a second, distinct mechanism through which this particular medication can affect how a person feels day to day, layered on top of the cardiac reserve effect already covered. It is worth being genuinely fair to metoprolol here, because none of this means the medication is a poor choice or should be avoided. Beta blockers remain essential, life-saving medications for a range of conditions where reducing the heart's workload provides real, measurable benefit, particularly for patients with certain arrhythmias, a history of heart attack, or heart failure with reduced pumping function, where the reduction in cardiac workload is precisely the therapeutic goal rather than an unwanted side effect. For blood pressure management specifically, in a patient without one of these additional indications, the calculation looks somewhat different, since amlodipine and several other blood pressure medication classes can often achieve similar blood pressure control without the same fatigue-related trade-off, which is exactly why current blood pressure treatment guidelines in many cases favor other drug classes, including calcium channel blockers, as a first-line option for straightforward hypertension without a specific additional cardiac indication, pointing toward a beta blocker instead. This is really the central tension worth understanding about metoprolol specifically. It is not a flawed or outdated medication. It is a medication whose core mechanism, deliberately reducing the heart's workload and reserve capacity, happens to be precisely the right tool for certain conditions and a genuinely suboptimal tool for others, depending entirely on what problem it is being asked to solve for a given patient. The same mechanism that makes it valuable for someone recovering from a heart attack is the exact mechanism producing unwanted fatigue in someone using it purely to manage otherwise uncomplicated blood pressure. So what does this actually mean if you are currently taking one of these two medications and have noticed fatigue that feels disproportionate to what you would expect from simply getting older? If you are on metoprolol specifically and have noticed a decline in energy, exercise tolerance, or a general sense of mental fog since starting it, that is a genuinely reasonable, well-supported thing to bring directly to your doctor, since the mechanism behind that fatigue is well established rather than speculative. There are several possible paths forward that a doctor might consider, depending entirely on why the medication was originally prescribed. If it was prescribed purely for blood pressure without an additional cardiac indication like arrhythmia or prior heart attack, switching to a different blood pressure medication class, potentially including amlodipine, may be entirely reasonable. If metoprolol was prescribed for one of those additional cardiac indications specifically, the calculation changes considerably since the medication may be providing a genuine, protective benefit that outweighs the fatigue trade-off, in which case switching to a different beta blocker within the same class, one that is less lipophilic and less likely to cross into the brain as readily, or adjusting the dose or timing, might address the fatigue while preserving the underlying cardiac benefit the medication was actually prescribed for. None of these decisions should ever be made independently, since abruptly stopping a beta blocker carries real risk, including a potential rebound increase in heart rate and blood pressure that can be genuinely dangerous, particularly in someone with underlying heart disease. Any change here needs to happen gradually, under direct medical supervision. It is worth mentioning that timing of the dose itself sometimes offers a simpler first step worth discussing before considering a full medication switch. Some patients find that fatigue feels more manageable when a beta blocker is taken in the evening rather than the morning, allowing much of the peak sedating effect to occur during sleep rather than during waking hours. This is not a universal solution, and it depends considerably on why the medication was prescribed in the first place, but it represents exactly the kind of low-risk adjustment worth raising with a doctor before jumping straight to a full medication change. If you are on amlodipine and experiencing significant fatigue, it is worth knowing that this is genuinely less expected based on the medication's mechanism, which means the fatigue may be coming from something else entirely: a different medication in your regimen, an unrelated health condition, sleep quality, or simply normal age-related changes that deserve their own separate evaluation rather than being automatically attributed to the amlodipine itself. This is exactly the kind of situation where a broader conversation with your doctor about your complete symptom picture, not just the assumption that a specific pill must be the culprit, tends to be more productive than focusing on one medication in isolation. The larger point underneath this entire comparison is one worth remembering well beyond just these two specific drugs. Not all fatigue experienced after 60 is simply age doing what age does. Some of it has a specific, identifiable, mechanistic explanation sitting in the very medication cabinet meant to be protecting your health in the first place. And the difference between accepting that fatigue as inevitable versus understanding its actual pharmacological source can be the difference between quietly living with reduced energy for years and having a genuinely productive conversation with your doctor about whether a different, equally effective option might exist. If this gave you something worth asking about at your next appointment, hit subscribe, because there is a lot more research-backed insight like this coming, and you will not want to miss it.